So I'm going to talk about biologics, which is, I suppose, the opposite end of the spectrum from, Peter Haddon's talk about outreach services in the Pacific. I actually used to run the eye clinic and the eye services on Norfolk Island, which is where most of the people from Pitcairn know. That's not my talk,
Not this
I'm
one.
afraid.
The first one.
But as I was saying, I used to run the eye services on Norfolk Island, which is where a lot of the people who used to live on Pitcairn Island went to. And I thought it was hard until I heard your talk. Now I realise I had a very easy clinic to run. Not that one. I've got another copy. How about? Which one?
It's the one that says AIOS talks. And the one that says biologics, that one.
This is like a biologic that is used in treatment of uveitis, but it can be used for any other immunosuppressive therapy also.
Okay. Okay, so good afternoon again, everyone. So I'm going to talk about something that's at the opposite end, I guess, of the complexity spectrum, but it's really dealing or how we're using these new biologic drugs. And so I'm just going to talk about how we use these very expensive drugs in the units where I work in Australia. And basically I work in Sydney, and I also conduct an outreach clinic down in Hobart in Tasmania. And we look after a lot of patients with inflammatory eye disease. And I just want to go through our experience using TNF blockers, particularly adalimumab or Humira, which is the drug that we've got the most experience with. These drugs have only been available relatively recently and in Australia since 2016. And I'm going to go through some of the evidence, which is these visual studies, and then show you how our experience in Sydney matches those studies. So there were essentially two important studies of adalimumab. They were both randomised controlled clinical trials. The first, called Visual 1, was in patients with active uveitis, and as you can see, basically the adalimumab arm of the trial doubled the time to disease relapse, and it's a very powerful effect on a group of very bad, frequently responsive diseases. The other study that was done was a similar randomised controlled clinical trial, but on patients with uveitis where the uveitis was in remission, and a similar sort of sustained early effect on uveitis was found, and less than 50% of the patients relapsed over the time course of the study. So these two studies showed clearly that adalimumab was a very efficacious drug, and there were minimal safety signals, so it was shown also to be a safe drug. There was a low risk of any other side effects. The two important lessons that they learnt from these studies was how important it is to exclude infectious uveitis, particularly latent TB, which has to be treated before you use a TNF blocker, because that will unmask TB if you use a TNF blocker. And that's very important in a country such as India and in most of Asia and the Pacific, where latent TB is very common. The other important disease to exclude is demyelinating disease in patients with intermediate uveitis, because intermediate uveitis, a small number of those patients do have demyelinating disease, and again, a TNF blocker makes that reactivate and progress much more rapidly than it would. So in our small case series study that we did in Australia, we had 89 eyes of 46 patients. The majority of the patients had bilateral disease. The spectrum of disease is very similar to that that's seen in other parts of the world. 40% of the patients, there was no obvious associated disease. 20% of the patients were associated with anterior uveitis, and the other 40% was associated with a range of posterior and panuveitis, such as sarcoidosis, birdshot, Behçet's disease, and multifocal choroiditis. The usual reason that we escalated these patients to a biologic was either because that we were unable to control their inflammation, or they had progressing acute threatening disease that we were unable to find a treatment that worked well enough with minimal side effects for us to continue with that treatment. Occasionally there were other indications like side effects from their current treatment, or they needed the biologic for their systemic disease. This rather complex slide, basically what you need to look at is, as we go from left to right, the column of patients in the dark blue disappears, because the blue are the patients on steroids, and as we move from presentation to starting them on immunomodulatory therapy, and where we are then going to start them on biologic as well, to their final follow-up, you can see that we got all but one patient down to a safe level of steroids or to 0 steroids. The pink and red column in the middle are patients on maintenance acceptable dose of steroids and a biologic, and the green column, which has got much higher, are the patients that are on an immunomodulatory drug and a biologic and are off steroids. And that's really the basic message of what adalimumab or Humira does, is it allows us to stop steroids and get patients off steroids and get them onto a stable steroid-free regimen of drugs that controls their uveitis. And the reason that's so important is that most of the side effects that we see in our patients in the longer term are related to steroids. Many, far fewer are related to the other drugs. Most are steroid related. The other important thing in this slide is in the red box down the bottom. Essentially, once we put the patients onto a biologic, patients stopped losing vision. The vast majority of them stabilized, and very few patients lost vision. It didn't really cause many patients to get an improvement in vision, but the key thing is it just stabilized and burnt out and controlled the disease at whatever level they were. And this slide illustrates that a little more easily. The blue are patients who improved in vision. The yellow or orange one are those that are stable, and basically the small column on the right are those that lost vision. And once we started the patients on biologics, patients stopped using vision, and the majority stabilized, and some had a further improvement in vision. And that's the first time in inflammatory eye disease we've actually been able to do this. Our experience in Australia is similar to the Visual 1 studies. The graph on the left are patients with active disease, and there's a profound sort of efficacy effect with that stops the uveitis relapsing, and it's similar in patients who have inactive disease when they were started on their biologics. And these two graphs are extremely similar to those that were found in the Visual 1 and Visual 2 studies. So basically, what I've tried to show you today is that this is real-world data that supports the visual studies. Using TNF blockers in our patients with vision-threatening uveitis greatly decreases the number of relapses. It greatly decreases the number of patients who lose vision. It basically stabilizes the disease and turns it off allows us to usually stop or at a minimum get the patients down to a safe maintenance dose of steroids. In the longer term, we can often stop their additional immunosuppressive drugs. And although we can't show it in this study, there's more and more data that shows the earlier you escalate treatment to a biologic, the better the outcome is. So what we do now in our clinic is when we see someone with vision-threatening uveitis, we start them on steroids, start them on a second-line agent, usually either methotrexate or mycophenolate, and try and stop the steroids. If we can, good, we just keep going with methotrexate or mycophenolate. If the disease relapses, what we do is add a biologic rather than going to another second-line agent, and that's increasingly becoming the treatment of choice. There's a very large randomised controlled clinical study that we're a part of called the ADVISE trial that's looking at the differences in outcome between doing that when the disease relapses, changing to a biologic versus changing to a second disease-modifying conventional drug. We don't know the answer yet, but we're about 95% of the patients are now recruited for the study. So I suspect we'll know within the next 6 to 12 months. The other important point is that our colleague Stephen Foster many years ago said that two of those famous American one-line sayings. The first was that the mission is remission. The most important thing we need to do in patients with uveitis is get the disease into remission. And the problem is, until relatively recently, we've always struggled to get the uveitis completely controlled. And more recently, the second important goal is that we need to get our patients, as they say, into durable steroid-free remission. We know that most of the side effects and most of the longer-term complications and adverse outcomes in our patients are related to steroids, so we need to get them off their steroids. And biologics are really the first time that we have a very effective, very safe, very well tolerated treatment that does those two things. So they're certainly the way of the future. Thanks very much.
Thank you.